So welcome to all who have tuned in for today's session. We have some very interesting speakers who have joined us, and today we are discussing the COP10 scorecard, which has been officially launched on thr.net's updates page on the website today, ahead of COP10 in Panama next week. So you can check that page on the site and also our social media channels for access to that scorecard. If anybody has any questions from the audience, please do put them in the Q&A section in Zoom. So for today's discussion, we are joined by our lead author, Dr. Derek Yach of the US and South Africa. And we have a few of the co-authors of the scorecard with us, such as Dr. Delon Human of South Africa and France, Dr. Kgosi Letlape, who will join us later from South Africa, and Dr. Abbas Raza from Pakistan. Welcome to you all for joining us today. All of our speakers are physicians, and they're all physicians and advocates for improved public health outcomes. So Derek, as lead author, would you be able to please introduce yourself briefly and then explain why the scorecard is so important and also how it works?
Thanks, Jessica, and a real pleasure to be with you all, and hello to everybody around the world who's watching. I have a background in tobacco control and global health, having spent several decades first in South Africa, luckily with the new Mandela government bringing in tobacco legislation, then at the World Health Organization, where I played the steering role in developing the framework convention under Dr. Gro Harlem Brundtland, before heading to the US in many roles, some involving tobacco, for example, at Yale, and then starting and heading the Foundation for a Smoke-Free World in recognition of the fact that harm reduction was underinvested in and that the time had come to give greater attention to it. For the last few years, I've been an independent consultant, continuing with my passion to end smoking as fastly as possible. So we undertook this exercise, and I thank all my colleagues who are on the report with me, really inspired by The Economist from the UK, who published a scorecard just before COP28 for the UN Climate Conference. And I just liked the way that it focused on making it transparent what countries were really doing, providing verifiable change or progress, and identifying gaps. And I thought that's a very cool thing to do. Let's see if we can get people to come together and do the same in advance of the COP10 meeting coming up in Panama in a couple of weeks. So I will give the results of our work, which is based on scrutinizing WHO's own documents and own reports, supplemented by other independent experts, to give a grade. And our grade is traditionally used worldwide, except in the US. A is the best, F is a fail. We do give E and D grades, which I believe are not given in the US because everybody fails under a C. So I'll leave it up to you to decide how you assess them. So the first question is, what are trends in tobacco use and impact? This is the real test of whether the treaty is working. And for that, we give an E- grade. The reason is because there's still 8.5 million annual deaths a year from tobacco, a figure that will probably grow to 10 million before it starts going down under the current scenario. We have 1.2 billion users of tobacco around the world, the 37 countries where over 40% of men smoke, and 22 where women smoke more than 20%. We have a real concentration of smokers in the Middle East, Eastern Europe, small island states, China, and Indonesia. And what worries me for the future is we now have many European countries where girls smoke more than boys, which means inevitably lung cancer death rates will continue to grow and exceed breast cancer death rates in women, which they already do in many countries. That, by all account, cannot allow them to get an A, B, or C grade, and that's why we give them an E-. Secondly, on commitments and resolutions, which I call words without action, we give them a B+ grade. To their credit, there have been several lofty resolutions. A number of countries are now starting to talk about getting close to the end game, where they define that as being under 5% smoking prevalence. There's been steady progress by many of the countries in developing national plans and budgets. UN agencies have linked to WHO in a number of ways. They report progress on what is called 5.3, or the focus on industry interference. I would say that the progress reported there is all based upon using US guidelines that, in the view of several legal authorities, were actually illegally developed. There is no basis to develop guidelines if it's not in the Framework Convention. It isn't in the Framework Convention. But overall, the words sound reasonable, B+. The real test then is, what is the impact on the streets? So for the implementation of resolutions, we give a D-. Very importantly, when you look carefully at the data, which are in all the WHO reports that we cite, most progress is reported by parties who already had a strong tobacco control program 20 years ago. That included countries like the UK, or Canada, or Norway, or New Zealand, or Australia. And in the developing world, countries like Poland, South Africa, Thailand, all actually 20 years ago had established reasonably good programs. Less progress has been made in low middle income countries, which were weak 20 years ago and remain very weak today. Some examples: data availability, which is the heart of deciding good policy, is very weak. Half of all the parties reporting do not report tobacco deaths, and more than half do not have national surveillance system. Outside of Europe, most countries have not met their excise tax recommendations. And remember that excise tax is probably the single most powerful means of lowering and slowing tobacco consumption. Most countries in low middle income countries have yet to integrate smoking cessation into primary healthcare systems. Half of all the parties have no capacity, by their own reports, to test the content of tobacco or related products. If you can't test the content, how can you do an assessment of whether it's harmful or less harmful to people? Very interestingly, bans on tobacco products to youth under 18 are almost universal. Yet smoking rates in 13 to 15-year-olds exceed 20% among boys in many countries, which actually represents a massive failure to implement the laws banning access to cigarettes. And I must add that if we're unable to achieve stopping access for kids to cigarettes, how are we going to do that with e-cigarettes? My fear is that there's more attention now being given to stopping access for youth to e-cigarettes, which may simply push youth back into cigarettes where already the rates are high. 80% of parties provide education on the harms of tobacco, which sounds good, but there's growing concern that the content of public awareness programs promotes disinformation about the harms of tobacco, the harms of harm reduction products, and specifically about nicotine itself. WHO's documents itself contribute to this confusion. For example, the recently published Global Oral Health Report draws no distinction between snus and nicotine pouches on the one hand, which do not increase oral cancer risks, and a wide range of toxic smokeless products that do. The advice to dentists is draw no distinction. Lives could be saved if they drew the distinction. The fourth area is the area of technology innovation, and that I would say is one of the most powerful omissions and worrying concerns that we identified. That is where we're looking at transforming a legacy industry through scientific innovation. For that, we give an F grade, a fail. The Framework Convention text is sealed in time. For 20 years, innovation has happened across so many areas of biomedicine, be it in neuroscience or cardiology or oncology. It includes areas of harm reduction. The COP10 documents, however, reflect a view and understanding of tobacco harm reduction that ignores substantial progress in reducing risk and harm, including, in recent years, documenting the direct and biomarker-based benefits of actually shifting to harm reduction products. The new COP documents focus on youth concerns without recognizing the critical need to end smoking in today's adults as the fastest means to save lives. Recent modeling exercises document the benefit of tobacco harm reduction when combined with other advances in technology in saving lives in low middle income countries and in advanced industrialized countries. And you can find more evidence of this and the data for countries as diverse as Pakistan, as South Africa, Bangladesh, and others on the website of this report. Proof that this works in the real world is now available in countries where we've seen combustible smoking rates come down faster than any independent effort by the government to actually do so. And this is in countries like Sweden, where snus has driven the rates down. Japan, where heated tobacco have driven the rates down. The UK and the US, where e-cigarettes are driving the smoking rates down. The benefits of vapes, snus, nicotine pouches, heated tobacco products, and I believe additional emerging innovations are all denigrated by WHO in its document instead of being embraced as the most powerful single means of lowering the death and disease rate over the next few years. The fifth area is new investments in R&D and capacity in low middle income countries. The rationale for giving an F is really based first upon the knowledge that little progress has been made in implementing many provisions of the Framework Convention related to research and capacity. The reason those provisions was there was because we know that no progress is made in countries if you don't have high quality local science and local scientists. Local science informs policy better. Local scientists create better science-based policymakers. Without that, you're reliant upon importing research from the US using the priorities of the US that get globalized with no change in their context or adaptability to the local environment. It should be noted that 90% of the publicly funded research in tobacco harm reduction comes from the NIH and FDA. Much of it addresses issues like, for example, how do we address youth access to vaping? What are the dangers of vaping? What are the negative aspects of the messaging that we need to address? Very little looks at the question of how do we bring the cancer rates, the cardiovascular death rates, the tuberculosis rates? How do we address mental health better through harm reduction products? Those would be the sort of questions I would expect a responsible national research body to fund. Virtually none of that is supported in low middle income countries. And it's been ignored for 2 decades. When I was at WHO, we did the first and last exercise to define priorities in research for tobacco control in general. It's long overdue this be updated, and now that we include tobacco harm reduction. For that, we give them an F. The sixth area is the alignment of the Framework Convention with the UN SDGs, the Sustainable Development Goals. And this particularly raises the fact that during the COP28 meeting, the importance of agriculture contributing positively and negatively to climate change emerged. We're particularly concerned about greenhouse gas emissions from some forms of agriculture, water use, child labor, and many factors. Those factors particularly beset the tobacco growing areas of the world. While World No Tobacco Day last year did address the negative effects of tobacco farming, few parties have been given the support to take the steps needed to actually transition out of tobacco over the long term. The one country that is making progress, Malawi, is doing it entirely because of the support coming from the Foundation for a Smoke-Free World, something that WHO does not particularly support. Yet that's where we're seeing the fastest progress. My own view is that over the next few years, we will see that the best way to improve the environmental, social, and governance aspects of tobacco companies, something that the investor community is looking at very carefully, is to have a planned, careful exit from using tobacco as a source of nicotine in all of the new products and in the medicinal products, and move instead to high-quality, patented synthetic nicotine products. If you did that, we know that you would lower the environmental costs, particularly related to water use, greenhouse gases, and the associated impacts on child labor dramatically. I know that in the next few months, more data on this will be released and will simply make that point. Failure to address this, particularly in light of the massive movement towards climate change, gets us to unanimously decide on an F or fail. In a slightly different note, we looked at a criteria which we called partnering for social impact. In doing so, we recognize that global governance, or the way we actually work together and integrate, is increasingly based upon all stakeholders with a material interest in an issue being involved. In the case of the Framework Convention Tobacco Control, we give them an F grade. Contrary to the general movement around the world to embrace people with diverse views, diverse science, be they from the private or the public sector or the nonprofit sector, and particularly the role of the user, the consumer, the people with lived experience, need to be part of the process of deciding what is in their best interests. You can't decide for them. You can't decide the science without having the best scientists, generally coming from the private sector, at the table and think that you're going to come up with solutions that can save lives. You won't. COP10 excludes all but a small group of non-state parties, 26 of them. A disproportionate number of them are US-based organizations like the American Cancer Society, the Campaign for Tobacco-Free Kids, that are heavily funded specifically to oppose tobacco harm reduction. These are not the type of institutions that should be sitting in an international body deciding international policy for all countries in the world when they have their own narrow interests at stake. We don't see much voice coming from many of the physician groups, the dental groups, the health professional groups, the users of alternative products, be they snus, be they nicotine pouches, or vapes, or heated tobacco products, or in the Middle East, new harm reduction forms of shisha. Those people need to be at the table, since they would have important comments to make. The failure to include them leads us to give them an F. Finally, the question of financing global tobacco control. We know that without serious funding, the Framework Convention will stay off track. Because they don't address this adequately, we give them an F grade. Very importantly, in the last couple of years, public health experts have calculated that $420 billion is needed to meet the funding gaps to implement the Framework Convention in low-middle-income countries. This is, if I might say, a pipe dream. They don't address the fact that there are two sources which could be addressed. Government funding using tobacco excise taxes remains a solid long-term source of funding if it's done responsibly. Many countries are simply not applying the excise taxes to the level they should, robbing government of potential revenue which could be used to partly finance tobacco control. And more importantly, leveraging the industry finance, expertise, research, and scale to end smoking within a regulatory environment that is proportionate to the underlying risks of the products. If government were to put in place a sensible regulatory framework and let industry do what it does best in every area of consumer goods and products, run their own research, get on with their marketing, get on with their distribution, make sure that nobody is left out, which is what happens in many areas of consumer goods. The cost of that being done by government would be reduced, and the benefit to the smoker and to those with smokeless tobacco products would be very high. Finally, based on these, we come up with a set of recommendations, which I won't go into in depth, but just summarize in a few words. Obviously, number one must be embrace tobacco harm reduction, don't denigrate it. Number two, improve the quality and timeliness of data of tobacco use and impacts. No data, no decent policies. Third, integrate private research and technology with publicly financed research when developing strategic reviews and policies. That doesn't mean have industry at the table when you're deciding the policy, but at least have the opportunity to listen to what they recommend. Fourth, focus attention where the smoking rates are extremely high. And I would say smoking rates in men in excess of 40% means they are extremely high. They're as high in the Middle East, in parts of Eastern Europe, in parts of China and Indonesia, as they were in the advanced industrialized countries 40 to 50 years ago. We're not going to make up, we don't want to wait 40 to 50 years. Cut the time to have the 40% rate come down. The only way to do it is through making tobacco harm reduction more readily available. And finally, we have to do far better to tackle disinformation and misinformation by engaging health professionals to be the truth tellers, but for that, they need to be armed with better evidence, better science, and better access to particularly the social media. Thank you.
Thank you very much, Derek, for providing such an excellent overview of the scorecard. I'd like to now go to Dr. Abbas Raza of Pakistan. Hi, Abbas. It's great to have you here with us today. I'm going to ask you a
Hello.
couple of questions regarding reducing tobacco-related death and disease in Pakistan. Would you mind, please, firstly introducing yourself briefly?
Thank you, Jessica. Again, my name is Dr. Abbas Raza. I'm a clinician. I work in the field of internal medicine as well as endocrinology, diabetes, and metabolism. I'm trained in US, currently practice in Pakistan. So that's where the background of myself is concerned. And I think the top the area of interest for me is the coexistence of different medical conditions associated with tobacco abuse and making the complication of those diseases even worse.
Okay. So in Pakistan, there is a smoking prevalence of 13.1%, and tobacco-free oral nicotine pouches are actually legal in Pakistan. So how do you think they can be used to prevent tobacco-related death and disease in the country?
Jessica, actually it's very important point, especially for the people. And again, as mentioned early by Derek, that there's certain regions with a certain focus on tobacco use or cigarette smoking, and has a different impact. The percentage of people who are smoking and what disease process that they carry. And I'll give you a quick example, which I've quoted in the past as well. Living in this part of the world, in which double burden of the disease, and with that I mean having diabetes and diseases, chronic diseases, infectious diseases like TB, is not an uncommon scene in this part of the world. And you add smoking to it, it just makes everything worse. And I think the importance of, and again, whenever we talk about less harmful or tobacco risk reduction, we mean we cannot absolutely take the risk out of the use. But again, as long as we are giving them an option of getting themselves, we have failed badly as far as just bringing up the awareness of uh, smoking and the bad effects of smoking. We have seen media campaigns regarding it. We have seen official statements regarding it. We have seen implementation of rules against tobacco use. But unfortunately, what we haven't been able to convince is how to make sure that these people can use lesser harmful alternatives and slowly get away. And again, this is not coming out of one. We have seen research that there's certain, apart from training as well as psychological training as well as behavioral therapies, combining that with some kind of an alternative and slowly tapering it off makes the smoking people, the people who smoke, less use it less vulnerable to continuing to use this, as well as having alternatives for a less harmful products would definitely. And to answer your question, yes, we do have pouches, but unfortunately the amount of work which needs to be put in to give you a perspective about what are the benefits of quitting smoking, what are the ways of to get to that point. And again, as Derek has mentioned, before we can see the actual decline in deaths of tobacco abuse, we are going to see the increase in tobacco related deaths. So that's something that we need to work on. So I think it's a multi-pronged approach that we need to apply. Restricting the use of tobacco or smoking in a form of cigarettes, giving them alternative, bridging that to probably quitting it or giving them alternative which are less harmful.
And we know that misperceptions regarding alternative products and nicotine can be an issue. So what can be done in a more simple and effective way in terms of educating the public and even healthcare providers on the relative safety of these products versus potentially more dangerous oral tobacco products and, of course, cigarettes?
So Jessica, again, thank you for just posing me that question, because that's the continuity of what I was saying as well. If you look at the general impression of the people around you, you would think that there's a question of either you smoke tobacco or you quit completely. Unfortunately, we don't know. And again, we see this in our clinical practice on a day-to-day basis. People, if they're asked to quit smoking, they resist it. They start changing the doctors. They start changing the physicians. That's problem number one. Problem number two is even in the most important or tertiary care centers, the amount of people who come to any OPD outpatient is so large to discuss the options of how, if they're smoking, how they want to quit, what are the safer means, are not existing in most of the physicians' consultation. And I think that's one more important thing that we need to look at, how to address the topic of smoking, safe alternatives, as well as how you can help them quit. And as long as we can provide these three bases for any physician or to the patients, it will definitely have an impact. Just to get an idea, it's not the first-hand smoking that you're doing when you're burning a cigarette. It's a second-hand smoking when the same burning material is inhaled back through the environment that you're breathing in. So you need to put an instance on how to make this environment safe for you and the people around you. Lastly, but not least, we talk about the bad effects of smoking, but what about the people who are already smoke, who are already having a secondhand smoke? How to prevent the complication in these individuals? That campaign has never picked up. Early detection of complication of tobacco use, early diagnosis of lung cancer disease. So I think just by increasing the awareness, you can reduce the people who smoke, but increasing the awareness on how to diagnose the complication will definitely have an impact on the number of deaths, number of complications, number of comorbidities that you see in people who smoke.
Thank you, Abbas. Now I'd like to turn our attention to Kgosi. It's good to see you, Kgosi, here. I have a question regarding harm reduction strategies. But would you briefly be able to introduce yourself first?
My name is Kgosi Letlape. I'm an ophthalmologist by training and a health activist by choice. For special reasons, I've stopped clinical practice post-COVID because of insurance issues, not because I've lost the competence or anything. So harm reduction is what I'm active in. I'm a co-founder of Africa Harm Reduction Alliance with Dr. Delon Human.
Thank you, Kgosi. So my question is, do you think that the WHO and COP10 delegations have been balanced in their consideration of harm reduction strategies? And if not, how could this be improved?
Well, they've clearly not been balanced. I mean, the FCTC refers to harm reduction, and the WHO pretends like those that authored the document made a mistake by putting harm reduction in there. And we need to remember that when the FCTC was signed in 2003, except for snus, there wasn't really any other risk-reduced product on the market. E-cigarettes only come on in 2013. Nicotine pouches come on around 2017. So there was really nothing at the time that pact was signed. We should also remember that outside harm reduction, if you look at the reduction of smoking in countries like the US, where with the report of the 60s, even doctors had a smoking prevalence of over 50%. So between the 60s and 2003, there was a more than 50% reduction of smoking in those countries. Why did that occur? Based on proper information and proper education, people made informed choices long before the FCTC came into place. So one of the key issues about changing behavior is giving people the correct information. And that is what really irks me when the WHO becomes the source of misinformation and the source of disinformation, where they've now leaped from saying, not differentiating between tobacco and nicotine. When you go into what happened in the medical profession, nicotine replacement therapy was produced because, as George Russell said, in 76 or in the 70s, people smoke for the nicotine, but they die from the tar. and nicotine replacement therapy came up. Now that there's over-the-counter nicotine alternatives, suddenly, with the WHO watching, nicotine has become the enemy. When, in relation to tobacco use, the greatest way of reducing harm is to be able to obtain your nicotine, but avoid combusting the tobacco leaf. Now, suddenly, because they're changing tech and there's no differentiation between tobacco and nicotine, it's now become a nicotine war, which makes it difficult to talk about harm reduction. So we need to ensure that the WHO is brought to come back to its senses about not telling lies, not supporting studies that don't make sense, not honoring ministers of health that do crazy things like ban vaping. So unfortunately, from where I stand, in terms of misinformation and disinformation, the greatest enabler is the WHO. The public health community is also not helping. You know, in South Africa, we have council against smoking. But what it turns out now is that they are against people who smoke. They are not just against smoking, they are against people who smoke because they'll ensure that people don't get proper information about alternatives that will be less harmful to them. If we're going to promote the harm reduction approach, the emphasis should be on reducing morbidity and mortality, preventing preventable deaths, and do everything we can to ensure that we can save the lives of smokers and improve the lives of people who smoke.
Thank you very much, Kgosi, for raising those very important points ahead of COP10 next week. So now we move on to Dr. Delon Human, and I have a question for you regarding regulation, technology and innovation. So can you please provide your thoughts and recommendations to the WHO and COP delegations regarding the roles of regulation, research, technology and innovation, please? And firstly, could you please introduce yourself briefly?
Thank you, Jessica, and it's a big privilege for me to be here with Derek and Abbas and Kgosi. I'm a specialist family physician, so a big part of my life was devoted to individual health and helping patients, which was a joy. And then I worked with the World Medical Association and have been involved in tobacco control for decades. So I also worked in population health. Just as a mea culpa, when Derek was working at the WHO and I was working as the Secretary General of the World Medical, we were actually part of the public health environment who failed to make a good distinction between combustible tobacco and smoke-free options. I remember in 1999 when we campaigned for the World No Tobacco Day, we still were saying that all tobacco kills, don't be duped. And as a big mea culpa now, we realize that this lack of differentiation is a big issue. And perhaps then just to answer your question, Jessica, perhaps it will be useful to look at the most important threats and the most important opportunities leading up to COP10 starting on Monday next week. So the biggest threat from your question in terms of regulation, innovation, technology leading up to COP10 is really number one, the lack of engagement, and number two, the lack of differentiation. Exactly what I've been referring to and where I was guilty of this malady myself. What do I mean in terms of lack of engagement? Well, the United Nations high-level meeting on the prevention and control of non-communicable disease, which focuses almost mainly on tobacco-related disease, calls for what they call multi-stakeholder engagement and multi-sector action. Now, the WHO, as one of the agencies of the UN, has ascribed to this principle. But if you look at next week's COP10, it's very clear that most of the private sector has been excluded from COP10, which is in stark contrast with what happened at COP28. I think Derek very eloquently mentioned that during COP28, all the stakeholders had a seat at the table, including non-state actors like the private sector. And that helped to give an inclusive debate where there was ownership of a societal problem. And this is badly needed within tobacco and tobacco control and harm reduction. So it is extremely important that especially Article 5.3 is not incoherently applied. And I'll give you an example. WHO, through Article 5.3, has excluded most of the big private tobacco and nicotine manufacturers. And bear in mind that not all nicotine manufacturers have anything to do with tobacco. But inside the whole, you have big countries that have significant stakes in their own tobacco companies, and they are completely part of the policymaking process. China, for instance, the government owns 100% of the Chinese National Tobacco Corporation, and that company is responsible for the manufacture of 60% of cigarette sticks that are consumed per year. So you have an incoherent and inconsistent application of the Article 5.3, which at heart was to try and exclude or to make sure that there would be no interference in policy making. What should be done is that there should be multi-stakeholder engagement, because engagement does not mean agreement. It means an inclusive debate. And more importantly, it helps to bring the right science from all the different sectors to the table. The second is what Derek also mentioned, the lack of differentiation. If WHO in the oral health strategy does not make a distinction between snus, which is an oral tobacco pouch, and oral nicotine, which is non-tobacco but nicotine only, this is a grave error where precision is necessary, because it involves people where you need to give accurate healthcare information. So this lack of engagement and lack of differentiation will make a big impact on the quality of decision making and ultimately policy making next week. Then what would be the biggest opportunity for next week? And my colleagues have already mentioned a few. If you have a treaty which is at this stage more focused on process than actual outcomes, you will always have a neutral to negative result. Whereas if the treaty would look at best practice throughout the world and then make sure that those practices are studied, make sure that all member states have access to the kind of evidence that is used in those countries, and then to replicate or at least emulate that in their countries, then we can have progress. So for instance, in Sweden, we have a country where there is a smoking prevalence of 5.6%. This is an extraordinary achievement. In essence, it's a smoke-free country. How did they do that? They linked tobacco control with harm reduction strategies and products. If you look at another category like heated tobacco, Japan has over the last 4 years managed to facilitate the conversion of cigarette smokers to heated tobacco products which are not combustible in about 40% of the smoking prevalence. So this makes a big difference, and you would imagine that WHO would be first to analyze what was done right, what was done wrong, and make sure that this technical advice is shared throughout the 194 member states of WHO. Likewise, in the vaping category, you have countries like the UK, where the government has fully embraced tobacco harm reduction. There's the big debate about modern disposables, but in essence, they've embraced harm reduction, and likewise New Zealand. So here you have 3 categories where a fire escape has been developed for the smokers in those countries. Tobacco control has been linked with and facilitated and empowered by harm reduction strategies, and that has caused a better outcome for individual health, for population health, and this is exactly where the opportunity is for WHO to take leadership. Make sure that, as they did with the COVID vaccine, that member states receive the most updated evidence and make sure that their policy making is based on evidence and not on ideology. So that, in answer to your question, is probably the most important threats and opportunity for next week.
Thank you very much, Delon. Just a quick question regarding oral health. Do you think the WHO gives enough attention to harm reduction strategies in oral health? And if not, why do you think this is?
Jessica, firstly, WHO did publish the oral health strategy in 2022, which is a big step forward because at least it raises awareness and it helps the 1 million dentists throughout the world engage better with their patients and their governments with the oral health issues in their countries. But if you look at the big burden of disease of oral cancer in those countries where smokeless tobacco is used in the mouth, as in Southeast Asia, it's another opportunity lost, where WHO could have brought in the differentiation between the various products, tobacco and nicotine products, which are used in different areas of the world, and they could have made a much better effort to identify, quantify, and help replicate the correct message to those countries where oral health issues, and specifically cancer, is at the order of the day. So the WHO report on oral health is a start, but unfortunately, as with the Framework Convention Treaty, they've missed the opportunity of a clear differentiation between harm-reduced products and pure tobacco products. And there, much more needs to be done to not only save lives, but to make sure that people have cleaner teeth, whiter teeth, a more healthy oral cavity, and that the low-hanging fruit of harm reduction can be taken on board very quickly. And actually, oral health is one of those areas where if today all smokers were to change to oral nicotine pouches, you would have a different oral health environment tomorrow.
Thank you very much, Delon. We circle back to you now, Derek. Do you have any comments regarding anything the speakers have said, or any closing remarks at all?
Well, I agree with everything they've said. I think they're all given wise, sound points. Maybe expand on one or two points. I think both Abbas and Kgosi appropriately point us to the fact that we're not talking about tobacco control as some vague entity. What it really is about is trying to stop and prevent and treat people who've got diseases like cancer, cardiovascular disease, tuberculosis, mental health. I mention that because we seem to have drawn increasing gap between the policy discussion and the impact on people's lives. But people don't die of failed tobacco control, they die of cancer. They die of cardiovascular disease. They suffer from mental health. Mental health is a particularly important case that WHO doesn't talk about in relation to harm reduction. We know that if you take a condition like schizophrenia, where 70% people with schizophrenia in most settings smoke cigarettes, the reason that they die 10 to 15 years younger than people without schizophrenia is because of their smoking pattern. Well, in the case of schizophrenia, simply actually addressing the treatment of their psychotic episodes without thinking about how you might transition them to a nicotine-based product is something that really requires urgent attention. Where it is addressed in the UK within the Priory Hospital Group, we know that you're able to transition people to vapes, and having a clean form of nicotine means that their overall antipsychotic medication use can go down, giving them better control, lower side effects. Why is that important? Well, there are millions of people around the world in treatment for mental health problems. Maybe if we were to actually encourage vaping use among many of those people, it would not only benefit their long-term health and survival by reducing tobacco deaths and disease, but improve their ability to manage their mental health medications far better and keep them in a better position. That's just one example of the failure of us to speak closely and intimately to our colleagues in the clinical world, in that case, the mental health professionals, the psychiatrists. I could give you similar examples in the area of cancer and cardiovascular disease and COPD, where a closer interaction between the clinicians trying to treat people with, say, COPD could actually have a bigger impact on their lives. If you look at most of the COPD medicines on the market and the way they advertise, they generally do not talk about the importance of having people stop smoking. Remember that again, like in mental health, 60 to 70% of people who diagnose with COPD or emphysema will be smoking. And we know that a year after their diagnosis, they will still be smoking because the physicians generally have focused on treatments to address the symptoms without addressing the underlying problem. Well, what happens if we transition them to vapes and e-cigarettes? Does it actually slow the progression of the disease and help them be better managed? Yes, the answer from our colleague Ricardo Peloso has shown in studies that that is certainly the case. So all I'm saying about that is it's long overdue that we reestablished what we had when Delon was heading the World Medical Association, close and intimate link between the clinical bodies, whether they're dentists, whether they are doctors, whether they are nurses, and tobacco control in the context of harm reduction, not what we have now, which is great pressure for them to stay away from this and shun it. Shunning it means they are harming the lives of their patients. Final point I'd say is about big numbers. I'm an epidemiologist at heart. And so when I look at the trends, I didn't mention the fact that one of the big shortcomings of the way the report is presented by WHO, that's the review of progress, is that they are required to do the report member state by member state. And we use the word party to the convention because not all countries are yet parties. The US, Switzerland, for example, are not yet parties. The problem is that when you look at the percentage of countries who've achieved X, Y, and Z, it doesn't tell you what percentage of the total population of the world actually is still at risk. So WHO can get away with putting out data saying that half the countries have made progress or 2/3 or whatever it is, without often telling us that in the case of the biggest countries, we have many where progress is not happening and smoking rates are still going up. Let me give you some example. Delon mentioned China, the largest country in the world with the greatest amount of smokers, and consuming more cigarettes than the next 4 or 5 countries combined. Well, the smoking rates are going up in men, not down. The smoking rate in men is 50%, exactly where it was in parts of Europe 50 years ago. That is not progress. If we go to one of the next countries with very high levels of smoking, Turkey, again, the Turkish male smoking rate in excess of 50%, going up, not going down. Egypt, the same, also in the top 8 or 9 countries in the world in terms of total amount of cigarettes smoked, going up, not going down. Vietnam, going up, not going down. Now, we don't think about these countries often as heavy countries with smoking, but they are in the top 8 or 9 countries consuming cigarettes worldwide. The question is, why do we not have greater attention focusing on these countries? Why are the countries themselves, particularly those in the Middle East, in Eastern Europe, in China, in Indonesia, encouraged and supported to embrace harm reduction as the only way to bring those 50% smoking rates in men down to maybe 25% within a decade and hopefully to 10% within another decade? That is what the COP discussion has got to be about, having substantial progress to actually bring the global burden down in the fastest way possible. And we hope this report will actually be read and spurred to action in many of the countries.
Thank you very much, Derek. Now, because of time, in just 1 minute, are there any closing remarks from anybody else here today?
Yes, I'd just like to say a few points. One is that we need to be mindful about the questions that are being raised about youth uptake. But what can't happen is for us to allow adults to die because we're concerned about youth uptake. We can chew gum and walk at the same time. So we don't need to lie about products just because we're concerned about youth uptake. And we need to address that issue. The second issue is the fact that you'll see that countries that have embraced harm reduction to one extent or another, Sweden, total harm reduction, the lowest number of people using combustible cigarettes. Japan, heat not ban, the greatest decline in combustible cigarettes than they have seen in many years. UK, vaping, the decreases that they see. The US, with what they have embraced. And all the countries that do not embrace harm reduction are not seeing the reductions. So the facts should speak for themselves. The last point I'd like to make is that it is sad that efforts of the WHO now are actually protecting combustible cigarettes, when we should be moving people from combustible cigarettes to the alternatives. And I say to the WHO, that is unacceptable. And we living in low middle income countries, as the rich countries embrace harm reduction technologies and the capacity to produce cigarettes doesn't go down, where are those cigarettes going to go? They're going to come into our countries, avoiding to pay tax. They'll be cheap. They'll be in the hands of children, and we'll have mayhem in our societies. The taxation laws have been great, but they only work when you do not have illicit product. Because illicit product doesn't pay tax, it's dead cheap. And that's what's going to happen in our countries. So my appeal to COP10 is stop protecting combustible cigarettes. Let us embrace harm reduction. Let us accept that there are 1.2 billion smokers that can't quit. We can't abandon them. And we need to give them the information. We need to make alternatives readily available so that they can make informed choices. Affordability, availability, and safety is key. So we need the WHO to be encouraging governments to regulate and regulate appropriately.
Thank you very much, Kgosi, for those very impactful and powerful last statements. And with that, I'll conclude the webinar just by saying that the COP10 scorecard is available on the thr.net website on the updates page. And do please check our social media channels, as well as the channels of our speakers, to access the report and today's recording. So many thanks to all of our speakers today for your time, and a big congratulations on publishing this important scorecard ahead of COP10 next week. So with that, I'll say goodbye.